Shannon, I know everything. Today we're going over the stomach. So to begin with, we're going to be going over dyspepsia. So with this, you can have one or more of the following symptoms. So epigastric pain, which is just here. Some burning, some postprandial fullness, which means that after you eat, you feel very, very full. Or early satiety, meaning that you have a full meal that typically you could eat, but you're finding that you can barely finish your meals. So the workup for this. So one thing to note is that if you have a patient who's over 60, they're complaining of these symptoms, and it's just a sudden onset or a new onset, you want to go directly to an endoscopy. So you don't want to do the H. pylori test or any other workup. You want to get that endoscopy to begin with. Otherwise, you would want to check patients for H. pylori. If that's negative, you're going to go ahead and treat them with a PPI and see if that's effective. So now we're going to go ahead and move on down to peptic ulcer disease. So you have two different types. You have a gastric or a duodenal. And so just a few risks that could lead to peptic ulcer disease. H. pylori is one of those. You could have use of NSAIDs or aspirins, neoplasia, or acid hypersecretion disorders such as Zollinger-Ellison. Now as far as the manifestations, so what you're going to see in clinic, so specific to a duodenal ulcer, you're finding that your patients complain of a hunger pain, and that once they eat, the feeling goes away, but then it comes back right after. With a gastric, you're going to find that the pain worsens with eating, so they're going to be fasting. They may find that they're having some weight gain because they're not eating due to that pain. As far as treatment, you're going to do PPIs for 4 to 8 weeks. If you didn't, and then you can also do an endoscopy. Well, you will do an endoscopy, sorry. And if you didn't find anything on endoscopy, you're still going to treat with a PPI, and then you're going to redo the endoscopy 12 weeks later. So now moving over to gastritis and gastropathy. So the differentiation between these, with gastritis, that's an inflammation. It's typically due to an infection or autoimmune disease. Gastropathy, there's no inflammation, and it's typically due to alcohol, NSAIDs, or an increase in acid secretion. As far as manifestations, they can have dyspepsia, GERD. History is a big point when going over this differentiation. So for example, NSAID use or alcohol use. If it's viral, you're going to find that the patient's going to have nausea, vomiting, and diarrhea. If it's more autoimmune, they're going to have diarrhea, loose stool, and pain that comes in waves. So now we're going to go ahead and move over to Shannon, and she'll take us through a few other disorders.
Hi everyone, so we survived a week of GI. It was just as fucking terrible as I thought. So Veronica mentioned gastritis, peptic ulcer disease with NSAIDs and H. pylori as the most two common culprits. So I just want to say a little note on NSAIDs and H. pylori. With NSAIDs, the biggest thing, if you do a scope and find someone has NSAID-induced gastropathy, is to switch to Celebrex, which is an NSAID or Tylenol. Celebrex is just a COX-2 inhibitor, I believe. So it doesn't have, because COX-1 is throughout the whole body, COX-2 is more specific, so Celebrex is kind of more localized. It doesn't have as many receptors in the stomach, I believe. And then Tylenol is not an NSAID, so that's good for NSAID-induced gastropathy, could change. And then with H. pylori, so if you suspect this or someone has dyspepsia, you want to check that first before scoping. For the breath test, no antibiotics, PPIs, or H2RA blockers for 2 weeks, and then NPO for 1 hour before the test. So signs and symptoms, dyspepsia, and you can get GI bleeding with H. pylori, because that bacteria is just infiltrating your stomach, so you get melena or hematochezia. And then consider B12 deficiency. Our professor mentioned with the Nepali population that his clinic treats, there's a solid association found between B12 and H. pylori. So moving on, gastric cancer, there was no specific red flags for gastric cancer, so I just didn't want to hit that too hard. Basically diagnosis, endoscopy, kind of just your vague symptoms plus constitutional symptoms, you could suspect that. And then gastroparesis, we often think of gastroparesis with diabetic patients. They can have autonomic neuropathy resulting in impotence and gastroparesis. And then what is gastroparesis? It's just a slow gut. So you're not moving things, maybe you're just not shitting as much, I don't know. Slow gut. And then postprandial symptoms, which you can imagine the majority of these disorders are postprandial, so worse after you eat. So diagnosis, EGD and gastric emptying study. You can remember that because it's a slow gut, so we're wanting to see is the stomach actually emptying food. And then treatment, diet, glycemic control, because of the relationship with diabetes that I mentioned. And then 2 meds that can help with gastroparesis are Reglan and erythromycin. And Reglan is metoclopramide. So the reason these 2 meds can help with the slow gut is because they're prokinetic, so they kind of just help the peristalsis and help move things along. So moving on, our next condition is Zollinger-Ellison syndrome. This is a hereditary where you have gastrinomas, little stomach tumors that produce acid. So stomach gastrinomas. The diagnosis is pretty easy, fasting gastrin level. So as long as you remember Zollinger-Ellison is associated with gastrinomas, if you see this in a question stem or answer stem, it makes sense that you want to check the fasting gastrin levels. And then signs and symptoms, abdominal pain, diarrhea is a big one for this. Refractory peptic ulcer disease, so it's like you're treating, it's not NSAIDs, it's not alcohol. You're gonna want to start thinking about Zollinger-Ellison. And then treatment, PPIs, surgery, and rule out other things. You treat PPI doesn't work.
So that's refractory PUD. That means you give PPI and it doesn't work. So I don't know why you treatment is PPI on there.
Okay. Maybe just, yeah, I don't know. Anywho. So then pyloric stenosis, this one we learned about in pediatrics, so it's kind of a resurfacing of this. There's two main red flags, kind of key findings that you'll see on a board exam. The first is going to be the olive. So you can feel a little olive mass, so I drew a little olive at the pyloric sphincter. So that would be like down here in your stomach, you just feel this little kind of olivey, tender, round circle. And the other one is non-biliary, it's not very bile-ish, projectile vomiting at 2 to 4 weeks old. So anytime you hear projectile vomiting, you have to think pyloric stenosis. So I remember I vomit up, I'm projectile vomiting olives. So you remember the olive, palpable mass, and projectile vomiting, and just have to relate that to pyloric stenosis. And it kind of makes sense of projectile vomiting. So if you can picture your food coming down, boom, and it hits the sphincter, and you can't go through the sphincter, you're gonna vomit it back up. So surgery, do not miss this answer on the test. Urgent surgical referral. Urgent, because it's a little infant, and they could choke on their aspiration or projectile vomiting, die. You have to do a pylorotomy, so do a little incision into that pyloric sphincter to open it up. So to conclude, these are stomach disorders. Thank you.